My name's Olivia Cohen. I am the Director of Early Stage and Engagement Services, and we're here to introduce Making a Difference, How to Participate in Aging Research with Mike Splaine. Here's our speaker today. Mike Splaine has spent more than 35 years working to improve the lives of older adults and people living with dementia. Since starting in 1988, he has helped families, caregivers, and communities connect with research, better care, and advocacy for improved policy. Mike is the owner of Splaine Consulting, helping groups turn real-life caregiving and aging experiences into actionable strategies for meaningful policy change and improved community engagement. Mike also manages the Aging Research Navigators program, designed to increase the engagement of participants in brain health, dementia, and caregiver studies. He engages with caregivers, older adults, clinicians, and researchers alike, bridging the everyday lived experience and the research world. Mike Splaine is known worldwide for bringing the real face of a problem into the policy arena to yield success with policy influencers. So, I will stop my share now, and you will get to meet Mike Splaine himself.
Very good. So, and by the way, who wrote that introduction? Good God. I will say this, though. I realized recently, being back in Boston, where my career in dementia started, that the arc of my career has gone from a time when the treatment for Alzheimer's disease was to back up the Black Mariah, particularly for people who are agitated, and take them off to the state hospital, put them in 4-point restraints, and cry when they died 2 weeks later of pneumonia. I mean, that was the standard of care when I first started working with people with dementia. I'd also reflect that, and of course we've come a long, long way. I also reflect that then as now, the gap between where we are and where we want to be in terms of quality care and support, medical treatment, even better understanding of how our society continues to stigmatize people with dementia in ways that are so destructive. The gap between those, what we wish and what we've got, is frankly the gap of volunteers. We don't have enough people in the dementia space right now volunteering for research. We've studied this carefully over the last 7 years, where we've been running part of our consultancy to advise and also run recruitment campaigns for a wide variety of Alzheimer research. And having studied it, we're sharing with you what we think you need to know to make a considered choice about whether or not you can become a part of a research project. So with that, disclosures are in order. This is our current client list. You'll see a variety of organizations. I won't say who my favorite is, but they might be tribal people. The last 6 years, I've been doing a lot of work with American Indians and Alaska Native tribes about dementia. And all I can tell you is, frankly, an Indian reservation is the best place in America to have white hair. I don't think anybody mentioned that I'm a part-time stand-up comedian here. So where are we going to go? I'm going to talk about the barriers and some of the solutions, and I want to start with what are our preconceived notions about research? What are the images of research that are kind of burned into us through our education, through our culture, and how does that affect whether or not we can even think we can approach being part of a research project? From there, I want to talk very briefly, but importantly, about how the ethos, the ethics of biomedical and social care, and even research, survey research, require that human participants in research be protected. And it's a prime directive. I want to talk about that. Want to review key vocabulary? one of the things we hear from people that are reach out to our navigators about participating in research is it's a lot of gobbledygook. And even that's a lot of gobbledygook. So, what are the key vocabulary? What are the words that can get thrown at you by a research coordinator who might be a PhD student at NYU who doesn't think about the fact that that's not you? Uh, Talk a little bit about what can you do, examples of studies, and we'll take questions off the chat or live. So, hey, here's our buddy. This is research, right? This is sometimes we have, the image of research is that we're going to be experimented on. We're going to be, we're going to end up like this guy. We're going to end up in worse shape than we started. That's unfortunate because the exact opposite is true. Um, Science, hard science, is fighting dementia through a variety of research activities. We all know about the two new recently blessed infusions. They came as a result of probably over 20 years of trial and error, mostly error. But research also includes not just high level research for treatments and through infusions, but also medical devices. Medical devices go through the same deliberative process, although frequently a little speedier than do medicines. We all know that research is studying pills. And boy, all you have to do, we had a foreign guest watch half an American football game recently. They are football in their culture means something completely different. And I think you probably know what I'm talking about. Their culture, it's soccer. And they watched a half of an American Football League and they stopped counting at 20 the ads for different pills. They're completely astonished. So there is biomedical research going into pills, thankfully. There's also a whole branch of research that doesn't get the same respect as the medical side or the device side in care and support. We all want to know what the it is in what is the magic or what is the special sauce, what is the it's called the mechanism of action in a caregiver support activity. And care and support intervention research has blossomed in the last 5 years, particularly because there are amazing opportunities to participate not just in person, but through the web. The most used care support evidence-based, that means it was tested through a clinical trial, Alzheimer caregiver support mechanism or program is 23 years old. Think about that. I know some of you weren't born. I get that. I get that. But oh, sorry, Shira. I just made Shira lose her coffee. Okay, but 23 years is a long time, and in fact, with CaringKind and its amazing commitment to people across all the spectrum of the disease, but particularly people in the early stages, it would be mind blowing to read in the introduction to the manual for that caregiver support intervention that upon the diagnosis of Alzheimer's disease, the caregiver must take charge of every aspect of the person with Alzheimer's life. It's a period piece. And that's why, because all these so-called standards that are tested through clinical process in care and support have to be updated to today's world. There wasn't Zoom 23 years ago, and I'm going to stop right there. So those are different kinds of research, but and I think, so when you say research, you go to a conference, you hear a speaker, and they say, I need volunteers for research. What I'm trying to do is paint a picture that there's a lot of different kinds of research. It isn't all heavy duty medical. It isn't all medical devices. There's a number of different ways. A very relatively easy and yet super important part of research is tissue donation. Research America and others have found that Americans strongly support organ and tissue donation for research. And in fact, one of the first grassroots efforts in Alzheimer research run by volunteers way back when was a brain donation program where people were voluntarily supported research by donating their loved one's brain to brain banks when they died. Tissue donation doesn't get a lot of noise. I think we're all afraid sometimes also that what will they do? What will that cardiologist do with my little vial of blood that I just said they could use for 50 years? We all get a little concerned about that, but again, there are protections. So tissue donation. So far we've talked about care and support, medical devices, pills, infusions, now tissue donation, a form of participating in research that frequently is low effort. Uh, we love this guy, right? Remember him? Surveys, that'd be great. Uh, but surveys are another important tool, and particularly as we start to really unpack the persistent stigma against our people with dementia, there are more and more researchers that are turning to surveys as a way of trying to understand and unlock what might be the worst ism of all, dementiaism. So surveys are another way of being involved in research. And again, we'll talk about protection in a minute. So it's a menu. There are pills, devices, testing on and offline supports. There are valid research going on in testing online cognitive tests. And there's on and offline supports. When you hear participate in research, what we really want you to think about is it's a menu. And one of the things our navigators do is they help people with look at and evaluate their situation and what might be a match. Jen and I are always trying to find something we call a couch potato research opportunity because we don't want anybody that has the altruistic impulse to participate in research to go away empty-handed. And what frequently happens is somebody will read a flyer about a study. They will call the number on the study. If they miraculously get a human and they don't fit the parameters of the study, they don't get referred on to anything else. And that impulse to participate in research is extinguished. Put another way, we're not aware that anybody, when we think about all the people we've worked with in clinical trial research recruitment, almost nobody is turning to research to help themselves in Alzheimer's. And it's certainly not a standard of care, as it is in oncology, for example, or in hypertension or cardiology. We have yet to make dementia research, referral to dementia research, a standard of care, even for the most advanced clinics, who frequently will refer people to one study they're running. And when they don't fit the criteria, they are left without any opportunity. But Jen and I try to find couch potato research opportunities. Our favorite one right now, can I tell this, Jen? I can tell this. Our favorite one right now is Michael J. Fox Foundation for Parkinson's Research is doing something called a grassroots smell test where if you sign up for this test, you get a little book with 30 little cards in it. You scratch and sniff, you fill out a survey. After you do a consent, you fill out a survey and you send it in. And it's essentially they're trying to crowdsource a way of detecting Parkinson's much earlier in the process through this smell test. It might take somebody an hour, but it makes a value. If we don't get 500,000 people doing it, it's not going to be the impact that we want it to be. So what about protections? The prime directive, sorry for the Star Trek inference there, that's a generational thing, but the prime directive in in research in the United States, particularly government-funded research, but also drug companies, device companies, everybody follows the same rules, is that human subject protection is a prime directive. What does that mean in practical terms? Well, first, you are assured of, when you participate in research, you are assured of confidentiality. You are assured that the fact that you are participating in research is not shared with anybody else unless you specifically allow it. That's kind of important. As we move the curve of dementia further and further to pre-dementia or asymptomatic dementia research, I think the the consideration, this confidentiality consideration becomes more and more important, as if there would be a way to find plaque in somebody's brain and treat it at age 35, would we really want our employers to know? Would we want our health insurers to know? So confidentiality, really important. The whole process, you maybe heard the phrase, or you maybe used the phrase if you're a researcher, you've heard the phrase informed consent. This is the core document that provides human subject protection. It tells you what's going to be done on what schedule, what the risks, known and unknown, might be in participating in research, what the potential benefits might be, how and where your data is going to be used, how long the study is going to be. The informed consent document is really long and detailed. And by the way, we have done a really good job. Ethical studies, ethical researchers have done a really good job in finding a way for persons that are moderately impaired by their dementia to give their assent to research, not just be signed into research by somebody who has a healthcare power of attorney. That's how far we go in protecting the notions, or protecting the rights of the individual. All human subject research is subject to monitoring and oversight. If you ever have, as Jen and I have, hang out in an Alzheimer research lab, there's a portion of the lab where, believe it or not, there are still 100 three-ring binders, which carries all the information about patient by patient in a clinical trial that are available to any regulator, but particularly the Food and Drug Administration, at any time. They can walk into a study, they can say, I want to see your binders. Yeah, I'm from Boston. I want to see your binders and see what's going on in terms of how up to date and accurate your records are. Every study offers an opportunity for direct contact in case of any kind of an adverse event. By the time a medication or a device gets to a large scale trial, phase 2 or phase 3, and we'll talk about that in a second, there is a fairly high degree of knowing what can go wrong. But even in the best of circumstances, there are things that are unanticipated. Remember those drug ads on the football game? I mean, how many possible problems can they get into one 30-second commercial? But this is why we take a phased approach in research, especially with drugs, because we're so concerned about human subject protection. These protections, by the way, the heart of these protections pretty much go back no more than 25 years in terms of law and practice. There was a time when there wasn't as much concern about human subject protection. So, oh, Jen, we put a new one in there. Sorry. One other thing before I talk, let me get really serious here for a minute. We are encountering more and more fraud posing as research. This is like a little caution light for everybody. And by the way, scamming people with soft thinking is an art form by several criminal gangs. They use the same cognitive tests, like the three-word recall or other cognitive tests that either doctors use or that uh, insurance companies use to try to find people with potential cognitive impairment. So these gangs these days are not only posing as research, but they start the call with, "Did you get your new Medicare card? Are you a Medicare beneficiary? What plan do you have?" Sounds friendly as hell, right? What do they find out when you answer yes to whether or not you're a Medicare beneficiary? That you're a senior or you're a person with a disability. Next thing you know, they go into a script that probes your thinking. Now, they may come at you with miracle cures, or they'll persistently ask for social security numbers or your text, a phone number that they can text. You have to be a little bit cautious, and you can confirm a study is valid by talking to CaringKind New York City or your physician, or ask the contact for the university or sponsoring organization so you can call back when it's convenient. But in the last 3 months, these fraud these fraudulent organizations posing as research are increasingly showing up on our radar screen. Well, let's play vocabulary, right? It was always my favorite thing in grammar school. Learn new words. So a clinical trial. Clinical trial is just as it says, it is an experiment in which we are trying to test a hypothesis, a belief that an intervention, caregiver intervention, uh, a smell test, a medicine is going to have a desirable effect. A randomized clinical trial is when we have two relatively matched groups of people that go through the same trial. Half of them will get an active ingredient and half of them will get a placebo. Now, in care trials, we often see that people will have the opportunity to be involved in a online caregiver education program, for example, that's being tested through the same methods that we test drugs, and they're not being deprived of the caregiver intervention. We work with a group out of Case Western that has sponsored Skills to Care. They think it would be unethical to deprive family caregivers of people with dementia of the skills they think they can transmit through their program. So their way of randomizing or uh, conducting experiment fairly is that they have something called a waitlist control. So you'll get the opportunity to get the learning, you just get it later than somebody else. Drug trials, device trials are set up in phases. Phase one are microscopic trials and almost never reach out to the community for volunteers. This is after animal models or computer-generated animal models prove that there's a substance that is not going to harm people unnecessarily. We move into a phase one trial that might be 15 or 20 people to make sure that there are no other surprise toxicities in a drug or a device. Phase two is a larger trial, probably 200 participants in a typical phase two trial. And a typical phase two trial tries to modulate, having found a safe substance, some hints that it is effective. Phase two is when we really get down to, is it effective and in what dose? Because that's important. Do you want to give people, presumably you want to give people the smallest amount of dose that will create the effect we want. Phase three are the big trials. Many of you probably read about Pointer recently that went to phase three, and there were thousands of people involved in Pointer. Most of them are going to be in the hundreds. And again, that's an important. So if you're thinking about volunteering and you talk to a researcher and they say, well, we're doing a phase two trial, I hope by going through this vocabulary, you might begin to have a picture of it's not new, but it's still in the testing phase and it may have more risks. There's a phase 4 in America. There's actually a phase 4 clinical trial in which drug manufacturers are required to continue to collect aftermarket data about the substances they have approved to go on the market. This is how we know, for example, that one of the continuing vexing problems for the MAB drugs in dementia is that people, particularly people with a particular genetic makeup, get small strokes. They get brain bleeds. And that's because we have phase 4 information collecting even after a drug is approved. Every study has inclusion and exclusion criteria. Who gets in, who gets out? What it is could be age, it could be neighborhood, it could be any number of things. In dementia research, it's particularly interesting that we frequently read protocols, that is the recipe for studies, where we want people 70 to 75 who have no hypertension, no diabetes, have a beautiful BMI. Are you getting the picture? I mean, we see some of these studies where the inclusion and exclusion criteria is kind of nuts because they're unicorns. These are people that don't really exist except as a scientific construct. And this is frustrating. This is why we like to get involved with researchers early, because we want them to be successful too. But those are inclusion and exclusion criteria. And one further editorial is those are not used if the drug gets licensed. So if there is a truly effective drug for frontal temporal dementia and it gets licensed, and by the way, different disease, fascinating national organization, fascinating progress by working with the ALS people on a couple of phase 3 trials. It's not going to matter unless there's a drug interaction, what other treatment you're in or what other shape you're in, you're going to get the drug. Screening is the step in the process where we determine through a conversation whether or not you fit the trial. And this is the point where even large Alzheimer's disease research centers sometimes have a screen for one trial, and don't even think about sending somebody across the hall to somebody that's running a more appropriate trial. It's just a fact. And so you screen out those folks that have the impulse to volunteer. If you get through the screen, you provide your informed consent and go through a baseline interview. So those are the steps. That's the vocabulary. It's not words any of us use every day, unless you're Jen and me. But that's not shouldn't dissuade you from learning this and being able to be a good consumer and put this to work. So we're important for progress, folks. There are so many vacancies. Any given time, just in the United States, there are 70,000 participants needed at any given time for Alzheimer's and related studies in the United States. Representation is especially needed from communities of color. We're also learning there are incredible income and education levels that make a difference, as well as urban rural. One of our newer clients has been knocking on us to get them hooked up with rural home and community-based services providers because they're trying to test whether or not their online program mitigates some of the problem that people who live out in rural communities may have in getting services. It's an interesting hypothesis. We have found over and over again the community organizations and service providers provide some of the best education and information about whether or not there is research or what research people might think about. But many, many people, and this is why we're here today. Well, here on a Zoom today is many people don't participate because they don't know they can. And as I said, it is not a standard of care that people with an Alzheimer diagnosis or identified as an Alzheimer caregiver get educated or informed about participating in research. Many don't participate because they don't know they can. So with all these vacancies, there's not only a vacancy sign out, but there are plenty of opportunities to explore here. I'm going to get philosophical with you for a minute. My grandfather was an Irishman, and we're so close. I have actually dual citizenship, so been there a couple times. And Grandpa used to say that if rocks were money, the Irish would be the richest people on earth. Uh, yeah, Shira, don't die laughing at that one, please. But it's true. The place is just full of, particularly the South, just full of rocks. Grandpa told a story about how when a new couple would get break off a piece of land from a larger farm that a newly married couple could call their own, that the village would clear the field. They'd just make a party out of it. No typecasting there, folks. They'd make a party out of it. And Grandpa said everybody carried a rock that they could handle. The big burly men, big burly rocks. The small children, smaller ones. But I think that's my metaphor for research. Or is it a simile? No, it's a metaphor. Everybody can do something. Everybody can do a couch potato, maybe do something online, maybe make a tissue donation. There's a lot of different ways to participate. But as you see these beautiful walls, you realize that a lot of audience participation made these structures over time. So what can you do? Well, there are registries, and I'm glad this is being recorded so people can go back. There are several national registries that you can find studies in that are many are government maintained, and so far um, they're still accurate and up to date, despite what you may have heard about how things have changed. So far, they're up to date, although when the government shutdown. See, we're from near Washington, and we just get infected with this stuff. But when the government was shut down, there was a warning on this NIA website about with health registries that it was not necessarily being kept up to the minute. So these are registries and searchable databases as a way to find research. We're going to tell you about a couple of studies that we're supporting right now. And then I think we'll take questions, and then CaringKind has a couple of studies you guys wanted to talk about. If I've got the battling, I've got the order right, the batting order right. There she is. So, as I mentioned before, we're working with Case Western, trying to recruit caregivers for something called Learning Skills Together. It's a program to improve complex caregiving, the really hard stuff. We need family members who have a diagnosis of Alzheimer's or a related disorder and access to the interweb. Again, this is all, these caregiver interventions are exploding. The study of them is exploding. And what's even more interesting is the delivery as we become more and more e-friendly from COVID is moving toward those kinds of ways of delivering. Another study we're supporting right now is Can Do. It too is an online caregiver course. It is co-leaders are eminent people in the Alzheimer field. Some of you may have heard of Guide. Carolyn Clevenger is one of the geniuses behind the Guide model. And Ken Hepburn has been working with and studying caregivers and what works in caregiver support for over 30 years. And he doesn't look a day over 70. But it Can Do is a self-paced program helping you with ideas around managing healthcare, legal systems, and finances. So as opposed to the chores of care, LST, this is the harder stuff to do sometimes in care. Last, we have working with Northwestern. Again, if you can't see it up on the top, there's something that says approved for posting, but we're working with Sage Leaf, a Northwestern-based study, which is to create a self-paced positive emotions building program. So to find or accent the positives in caregiving. Again, if you're a primary caregiver, that's one of the basic eligibilities. So those are the ones we're doing. I think trusted providers, as CaringKind is doing, can make a difference. Talk about research as a standard of care, provide staff education, invite those researchers away from their towers at Columbia and get them talking to real human beings. And even better, call our friends at Sinai, like Mary Sano. She would do any presentation to families at the drop of a hat and quote us. We worked with Mary for many years. Connect residents and family and promote research avenues. There's my contact information. I'm going to turn it back to my boss for the evening.